good evening, everyone. Welcome. We are having 29 people. I think more people will start pouring in, but we will already start with our zooming in for today. Welcome, everybody. Good evening or good morning, depending on where you are. In fact, you can let us know in the chat from where you're watching. So this is the fourth episode of the Zooming In webinar series. And this is the first time actually that I'm not doing it from my living room at home, but I'm actually in the new Mind office. So that's why it's a bit of a different scenery right now. And so the Zooming In webinar series is a webinar series about psychedelic therapy and neighboring disciplines. At each episode, we have in-depth conversations with researchers and clinicians involved in psychedelic therapy. At this moment, it's always time for a disclaimer. When we talk about psychedelic therapy, we mean overground legal therapies that take place in a very controlled environment, in a professional clinical setting. We do not endorse underground use of psychedelic therapies. So today's plan is I will have a 1-hour conversation with our guest for today, Fernanda Palhano-Fontes, who will introduce herself in a bit. And then after that, we will have a half-an-hour Q&A session. Please use the Q&A button on the bottom of your screen for posting your questions. You can already post your questions while Fernanda and I are in conversation. Don't wait until the conversation is over to post your questions. Do not use the chat for your questions to Fernanda and me. You can use the chat for technical questions, for remarks, or just for chatting with one another. And you should also keep the chat open because in the background we have Abigail Calder, one of our fantastic interns at the Mind Foundation. She's doing the technical hosting today, and she will, among other things, post interesting links to papers, related events, stuff that is related to our conversation. So yeah, keep the chat open so you don't miss that. Yeah, and now it's my pleasure to introduce our guest for today, Fernanda Palhano-Fontes. Fernanda, great to have you on the show.
Hi, it's a pleasure to be here also.
Yeah. Fernanda, can you say a few words about who you are and what you do?
So I live in Brazil, in a city called Natal. And I started studying electrical engineering. So I have a bachelor degree in electrical engineering. And then I did a master's and PhD on neuroscience. When I finished my PhD in 2017, I was hired for the University of Rio Grande do Norte, the same institution that I did my PhD, as a research engineer, and I worked there in the Brain Institute. Currently.
So this is one of the peculiar things about ayahuasca research in Brazil is that you are actually an electronic engineer. You're not a psychiatrist or a psychologist, and yet you're the first author of a groundbreaking paper on psychedelic therapy. So like when we talk about psychedelic therapy research, we refer to psilocybin research, right? The trials at Johns Hopkins University for end-of-life terminal anxiety and depression associated with terminal illness. The trials for treatment-resistant depression at Imperial College, or the addiction trials in the United States. And this is usually the first authors are psychiatrists, or maybe psychiatrists. And you're an electrical engineer, so congratulations on that.
Yeah, this is very funny because I'm an electrical engineer. My advisor, who was my advisor, Braulio, he's a physicist. So it was like completely, different from every trial we had.
Yeah,
But
and it
yeah,
still worked.
yeah, it worked. Yes, maybe because we didn't know how it was.
Yeah.
You know, like when people, if you know already at the beginning how it's hard or so the difficulties you can find, maybe you stop before starting. But as we didn't know, we did.
Yeah, so we will find out more about this. You will let us know a bit more about this study, but I really want to point this out that this is, so when we talk about psychedelic therapy, we usually mean psilocybin or LSD in research, but this is actually the first randomized controlled trial in psychedelic therapy in the world that was done in Brazil, and it was done with ayahuasca.
Yes.
Again, congratulations on that. So this was a study that was published in 2019, I think.
Yes.
There was a preprint.
The printed version. Yes.
Right. Yeah. So the preprint, I think I already read 2 years before, like 2007.
Yeah, the preprint was we posted 2017.
Yeah.
2017.
So it has been around for a while, these results. But so I imagine that this is really a huge collaborative effort of a lot of people working on this. It seems to me that this paper is really only the kind of the tip of the iceberg of collaborative effort. Yes. Maybe can you say something about the history of this study, like preparatory work, pilots?
Yes. So yeah. So the history of this study begins in 2006 still, when Braulio de Araújo, he was my advisor, and I work with him today at his lab. And in this time, he was in Ribeirão Preto, São Paulo. And it was when he started to study ayahuasca effects in healthy volunteers. And then he heard about some anecdotal reports of regular consumers of ayahuasca that when they start to using ayahuasca, they get better from depression, from anxiety. So he was like curious about this fact, and he and his colleagues decided to test ayahuasca in the context of the hospital, in a clinical context. So they did the first open label trial with only 6 patients who had treatment-resistant depression, and the results were very promising. So they extend this trial to do another open label trial. So open label, it meaning that everyone knows that the substance that will be used, it was ayahuasca. Both patients and the doctors, the investigators know that it will be ayahuasca will be tested.
So no placebo condition, right?
Yeah, no placebo condition. And again, the results were very impressive. They found the depressive symptoms were decreased already in the day of the session. So you are talking about one session, only one session, one dose. And this, the depression severity decreased on the day of the administration and lasted for like about 3 weeks. So this was in 2010, yeah, in the early 2010. And then in 2010, Braulio moved to Natal, and I started doing my PhD with him. But my master's with him. But in the master's, I studied the default mode network under the influence of ayahuasca in healthy volunteers. There was nothing with the depression. But in the middle of my master's, we had the opportunity to run we know that we could run the trial here, the continuation of the trial. So the second phase, this placebo-controlled trial here in Natal. And then we decided that this was would be my PhD project, and we start to prepare the trial. So for about 1 year, we had meetings with all the team that included psychiatrists, psychologists, biochemists, a lot of people. At the end, the team was about 25 people, I think, among students and investigators. And for 1 year, we prepared, then we submitted the project to the ethics committee for approval, which took about 1 year also to have the approval. And then we finally started the trial on January 2014.
Yeah.
So it was like a long preparation. I could say like almost 3 years preparing before starting the trial.
Yeah. And then you treated how many? 30 patients? 30?
Yeah, we include 35 patients. 35, but at the end, 6 of them had to be excluded, like for inclusion criteria, like we do the screening, and then they had this score to participate, but in the day of the session, they had like low scores, then they didn't have depression for the like
right. Good for them, bad for you.
Good for them, and they yeah, it's not a very uncommon thing. People can get better for the expectation to participate in a new treatment.
Sure.
It's like a placebo, but before taking a placebo.
Yes. Okay.
And yeah, so the final sample was 29 patients with treatment-resistant depression, and also 50 health volunteers, because we designed this trial also to investigate biomarkers for depression. So we wanted to have this control group without depression to compare the scores, the evaluations.
Right. Okay. Yeah. And so among the people with treatment-resistant depression, am I right to assume that this is usually defined as people who have depression and it does not respond to treatment with antidepressants?
Yeah, there is some definitions. What we used was people who not respond to at least 2 previous medications from different classes. So an SSRI or IMAO or a tricycle antidepressant, for example. Yeah. But indeed, like I think people, so the patients had to be in a moderate to severe depression episode at the moment of the trial. And I think most of them had at least 10 years of depression. And also they had tried like a lot of medications, not only 2, but in average 4. And we had like patients with trying like, I don't know, like 15 medications on their lives. Right. And so even like 2 patients had done electroconvulsive therapy before, which is the gold standard for treating treatment-resistant depression. About the patient, I also think it's important to say that most of them had some personality disorder. I think this is also a particular thing in our trial, because normally this kind of comorbidity is excluded. It's a exclusion criteria.
So people in the psilocybin trials in Europe or the United States, when they have borderline personality disorder, for example, they get
and most of them was, in your case, we had like most of them, it's from cluster B. It's borderline or histrionic. So
right. Okay, so this is really another particular thing about this study.
Yeah, because I think it's very hard. I don't know, as they were very, their depression was very severe. It's very common to have things together. It's not only, it's very hard. You have someone who has only depression and not anxiety together, or not had a little, even if it's not the most prominent in his case, but it always has a little bit of something else.
Yeah, and also
so I do not exclude.
How about the socioeconomic status of those people? That's another thing that's
so
usually
this is also this is a very good
bias, right? Normally, people who get included in such studies are normally people who are in a good socioeconomic position.
Yeah, no, it's not the case for our patients. So they were like most of them were women, and from low socioeconomical and also education level backgrounds. They were not like, they did not receive very formal education, most of them.
Right. So that's another
Yeah, this is very interesting also.
And the strength of the study, really. Okay.
Yeah.
How did you prepare those people for the session? So in Europe or in standard psilocybin therapy studies, people usually have a kind of an introduction or a preparatory sessions, 2 or 3 sessions. Did you also do that, or did people just get ayahuasca?
No. So, like, for us it was like people underwent the screening, and once they agreed to participate, we schedule a week, because the whole experiment took 4 days.
That's remarkable.
So 4 days. So normally they arrive at the hospital on Tuesday, and then they had this first assessment with a psychiatrist to record the baseline scores for MADRS, and to have this the severity depression baseline. And then they pass for a lot of evaluations, like including neuropsychological tests, fMRI acquisition. Then they slept at the hospital, and we did sleep EEG recording during the night. Next morning, we took saliva and blood samples, and then after a light breakfast, we prepared then to the session. So it's before enrolling in the trial, the psychiatrist told how will be the trial, explain all the steps, and yes. But in this session, it was the preparation session.
Right. Okay. So no.
But it was like just before, like 30 minutes before starting.
Wow. Okay.
Yeah. So in this conversation, we explain again if they could receive either ayahuasca or placebo, that we didn't know, and not also he did not know also. And we explain, for example, that he could receive ayahuasca and feel nothing, and could receive placebo and feel something. So to explain, to also to cause a little bit of confusion. For the placebo.
Yeah, the placebo, I want to ask something about that. The placebo condition, that's really a problem in psychedelic research in general, right? Because people are assumed to, psychedelics have strong subjective effects, and people are assumed that they know when they get a psychedelic or not. So you did something really, really nice and really elaborate in your study. Can you explain that a bit, how you did the placebo condition?
Yeah. So it's, I think like producing a real placebo in psychedelics, it's a big challenge. It's no one knows how to do it, and so we tried some strategies to address this issue. The first one was all patients were naive to ayahuasca, and also to any other psychedelic. So it was the first psychedelic experience for them. And second, we developed a placebo trying to mimic some effects of ayahuasca, especially in this related to nausea. And so the placebo provokes some gastrointestinal distress.
So it looks like ayahuasca and it smells like ayahuasca and
and
tastes
yes, so yeah, it was like yeah.
and it makes you sick like
We tried to make like acid and a little bit bitter also, and the color, the brownish color also.
Mm.
Yeah.
And what's the name of the agent that gives you the
we
nausea?
make it the zinc sulfate.
Oh, right. Okay.
Zinc
And
sulfate.
have you tried it? Have you tried the
Yes,
placebo?
awful. I
Not-
can assure you that ayahuasca is better. The taste of ayahuasca, yeah,
is even better.
not very. Yeah, it's not very.
All right. So people got really sick from it. The
Yeah,
same way they do from
not really sick, like not sick, but yeah, it was not. Yeah, it's something very. You can get like 100 ml of this. It's not a very good experience, I think.
I
you can feel it, yeah.
And did people actually get nausea and vomit and in the placebo?
Some of them, we had like a lot of them feel nausea. I think 2 of them vomited and 1 had diarrhea.
Oh, okay. So
from the placebo. Huh?
Yeah, right, from the placebo.
Yeah.
And did they believe, like when they were asked afterward, did they really believe they had taken ayahuasca?
Yeah, from the placebo group, we had like 15 patients in the placebo group. And at the end, 5 of them believed that they took ayahuasca. And 2 of them responded, when you look at the clinical response, at day 7 days after dosing, they they had a clinical response.
Oh, great! Yeah. Okay, so that this really seems to be the fact that it was really an effective placebo condition.
Yeah, and lastly, we also had a team of 5 psychiatrists, and we managed to the psychiatrist who was in the experimental session, the dose session, was not the same that evaluated the patient after. Because even if you are like with the patient at the moment of the dosing, it's very hard that you don't know that he drank ayahuasca or placebo. So we try to make this team of psychiatrists to also to diminish this impact.
Yeah, that's good. Okay. And in the dosing session, how can I imagine that? Like, is it comparable to the way that ayahuasca is taken traditionally, or are people alone, or is there someone with them?
So we bring to the hospital some parts of the ritual, I think. So after this conversation we had with them, so also before the intake, we also explain some strategies that they could use to alleviate anxiety or some kind of bad feelings they could have, and we also ask them to pay attention to their emotions, to their body, to the thinking, the thoughts, what they are thinking. And we ask them to have an intention. This is a very common practice in the religious context. This intention can be a question you want the answer, or a problem you are having, or some a wish you have. And it works like a guideline through the experience. So we ask them, and also we bring some music from the rituals.
So it's
we had a playlist.
So it's like a ceremonial music, or
it's not ceremonial music, but it's like one of the church, the União do Vegetal. They listen also Brazilian music and some Andean music also. So Luis Fernando Toffoli, who was also an author of the paper, the work, he made this playlist, which is available on Spotify. I think you can find on Spotify.
Great.
Yeah. I think it's Ayahuasca therapeutic playlist, some kind of the name. It's But if you look the Ayahuasca, Ayahuasca project.
Maybe Abigail can search for it in the background and post it in the chat.
I think it's 2 playlists, one from the instrumental music and another one with lyrics.
All right. Okay. Great. Yeah. I will have a listen to that.
Yeah. So we bring these from the religious context in some way, and then the during the intake, me and normally Braulio stayed with the patient, not in the same room, but in the next door, like in a closed room.
All right. So the patient is actually alone in the room.
Alone, but with the door open.
Mm-hmm. And then the next door is an electrical engineer and a physicist.
Yes.
Great. That's great.
Yeah. And the psychiatrist was like in another room, closed also.
Okay.
Like it was like 3 rooms, very door to door, like this. Yeah. And but who was like looking to the patient all the time was me and W. Normally,
okay.
Yeah.
Right.
The psychiatrist only talked to the participant like 4 times at the baseline, and then in some moments to apply these questionnaires to depression.
Okay. And then, how is it after the session? Is there any integration session or any psychotherapeutic process or? Yeah.
So at the end, when the effects subsided, we did a free interview. So we asked the patient to tell us how it was the experience, what they feel, and also we applied some structured questionnaires as this MEQ questionnaire in the hallucinogenicity rating scale also. Mm-hmm. Okay. And then they went home. And next day, they returned to the hospital and we did the same evaluations again. So again, psychiatrist, psychological measures, fMRI, sleep EEG, and next day, saliva and blood sample collections. Mm-hmm. And then they had a last assessment, the last interview with the psychiatrist. And we did also the last interview with him, with them, and again we asked how it was the experience, if they had dream about this night, or some questions that I think at the end was like an integration session. So to answer your question, I think we can compare to the psilocybin studies, the trials, but in a more flexible way. We didn't have these preparation and integration sessions well structured. It was more a conversation, we were like feeling if the participant wants to talk, but if he didn't want, so it's also okay. We was more free. But and we didn't also. I think it's different. We didn't have any psychologist or therapist in the process, so it was not a psychotherapy assisted. I cannot say. So some of the participants were doing therapy, but not associated with the trial. It was some of them were under therapy and they didn't stop, but we didn't have this part of the therapy associated in the trial. But at the end also, I think me and Braulio worked as the therapist in some way. Yeah,
I mean, I imagine you must have developed some therapeutic intuitions and
but it was I think intuition was the word. It was intuitive.
Fantastic. Okay. So let's have a look at the results. I suppose everyone is waiting for that already. I can share my screen here. I hope everybody can see it. So this is the main results from the paper. Can you explain a bit what we see here?
So, yeah. So what you see here is in this X, we had the depression severity, the Y-axis, and bigger the score, more severe is the depression. And in the X-axis, we see the time. So we measured the depression severity at the baseline, 1 day and two days and 7 days after the dosing session. So in red, we can see the ayahuasca group, and in blue, the placebo group. So what we observed already at day 1, we had a lower depression severity in the ayahuasca group compared to the placebo. And this effect is bigger 7 days later. So indeed, we had like the big effect size was on day 7 days after the dosing. This is very interesting because of two things. One is that these patients had treatment-resistant depression. So normally they would not respond to the treatment. And second, we already see an effect 1 day after. And we know that this is not the case for the conventional antidepressants, which takes about 2 weeks to starting a clinical response. So yeah, this was very promising results. We're very happy to see this. Also, if we compare with our previous trial, the open label, the effect size was comparable. The within subjects effect size was comparable. And we also compare with ketamine, which is now the new antidepressant that has this rapid effect. And also the effect size was comparable, the same kind of size. But the ketamine, normally they see an improvement on day 1, mm-hmm. which is not lasting until 7 days. Mm-hmm. And so yeah.
How is it? How long? So 7 days. That's great. But do we know a bit more? Like how long lasting were these effects?
No, we mm-hmm. tried to do so. We designed the trial to have follow-up assessments at day 2 weeks and once per month until 6 months. So 1, 2 until 6 months.
Yeah.
But then we had some problems. It was like people didn't return to the assessments. Even if you call them, they didn't show up. Some of them didn't show up. And also on the 7 days after, they start a new medication. So one thing I didn't talk, it was during during the experiment, patients were in washout. So they were not taking in antidepressant drug. So we profit this washout period to do the
because antidepressants are dangerous to take together with
yeah, so can be some interaction between especially these SSRIs and the ayahuasca. So they were not taking in drug and antidepressants. All of them were taking benzo to sleep. But yeah, so 7 days late, they had to start a new medication. So it was like also a confusing factor to have this. Yeah, so we didn't. I think 1 month we still had some effect, but then after 1 month, like I had in 3 and 4 months after, I had like 3 participants that show up and 2 in a group. So I don't have any statistical power to analyze.
Right. It could mean many things. It could mean that people were so well that they never wanted to come back. But it could also mean that people were so depressed that they didn't.
I think both. Yeah, I think you're right. Like because after all, sometimes I try to ask to the psychiatrist, because most of them were treated at the hospital. So I tried to contact the psychiatrist to know, like, they are showing up in normal assessments, or yeah. And for some of them, they were better and didn't show up, and others were like worse and could not manage to go to the hospital. So right. It's true.
Okay.
Yeah.
Right. Okay. So let's talk a bit about the therapeutic mechanisms here. So how would you explain these antidepressant effects? Do you have any favorite explanation on what happens there?
No. So
what's important is that it works, right?
It works, but we don't know how. We don't have a single explanation, but as I said, we tried to gather a lot of biomarkers to also to know what was happening and why the ayahuasca has this antidepressant effect. So what I can tell is we had some potential mechanism that could be influencing in this result. Mostly from the biochemical markers that we have. So first we collected, we assessed cortisol levels. Cortisol is this hormone related to stress, and that's implicated in depression. So what you saw was that at the beginning, at the baseline, our patients had lower levels of cortisol than the control sample. Lower. This is not common. So the hypothesis is that patients with depression have high cortisolemia, but in our case, we had hypocortisolemia. And after taking ayahuasca, the group that took ayahuasca regulated the levels to the same level from the controls. And it was not the case for the placebo. Mm-hmm. So this could be a possible mechanism. Another thing we measured was the level of BDNF, the brain-derived neurotrophic factor, which is a molecule that it's implicated in the physiopathology of depression also, and related to neurogenesis. And again, ayahuasca increased the levels of BDNF one day after, when we measured one day after. And also we published a paper, like, I don't know, last month, and where we showed that some inflammatory biomarkers, as the C-reactive protein, which is not specific for depression, but normally patients with depression have higher levels of C-reactive protein. And we observed that one day after the dosing session, this level, the level of C-reactive protein was decreased in the patients. Mm-hmm. So this also could be a possible mechanisms. So these from the biochemical, but by this molecular perspective, and also some theories that we not tested, but could also play a role. It's we know that DMT is a sigma-1 agonist, and sigma-1 is a receptor that also seems to have to be important in depression. Or even we know also that the Armal alkaloids, which are part of the ayahuasca composition, are monoamino oxidase inhibitors, which are until today, a class of the antidepressant. So that's like a lot of pharmacological possible explanations for that. Okay. But we didn't know which one, or even if all together can have a
right. So did you look at any psychological explanations too, or
So this is from our perspective. If you think about the patients, what the patients said about, no, and some of them referred to the experience of ayahuasca as a therapy session. So it seems also to have some psychological. So we know that at the end, the psychological is also biological or chemical. But if you can like separate the two of them, and you look to this psychological level, so participants said spontaneously, we didn't ask, you think that this is like a therapy session,
right?
But they spoke like, explain how it was. Oh, it was like a therapy session, or I didn't like it, the experience, because it was like a therapy session.
Right. Right.
So it seems, we have some kind of psychological measure too. We didn't have a psychological measure itself, but it seems also that this kind of that's a psychological thing that you cannot explain, we cannot measure, but it's also important to the experience, to the result.
Right.
I think so. Yeah.
I have some hypotheses about psychological processes here. I don't want to annoy people with my always the same views.
Tell me.
My theory is that it's very much related to what you said about ayahuasca sessions being a bit like therapy sessions, is that in the psychedelic state occasioned by ayahuasca, people may be going through a learning process that helps them find different ways of relating to challenging emotions, to perhaps emotions that are otherwise avoided, or where people do not have healthy coping mechanisms for. And that is the state occasioned by ayahuasca. It evokes a lot of negative emotionality. Probably also the nausea and the kind of physical suffering would also have a supporting effect on that. And that people's usual coping mechanisms, for example, avoiding looking away from the painful stuff, it doesn't work very well in the psychedelic state. It actually makes things worse. So people can have the learning process that when they find a more accepting way to deal with what they're experiencing in this state, that they're actually doing better. And then they can have new experiences and new insights related to these emotions. And one hypothesis that I would have is that people who have very high baseline levels of emotional avoidance and very unhealthy emotional coping mechanisms, that when they take ayahuasca, they should suffer a lot more than when somebody with healthy coping mechanisms, who's able to accept their negative emotions, takes ayahuasca. So my hypothesis would be that people with depression, for them, ayahuasca sessions are more horrible, so to say, more challenging, more suffering. Is that something you observed in your...
It makes total sense to me. In like, one thing I want to add is like, in this preparation session, one instruction we gave to them was let it go. So if you are experiencing something like very nice and very pleasant, didn't hold, it's like let it go. And also do the same if it's a bad experience. It's if it's difficult, if it's sad, or I don't know, let it go. So don't try to push them, but wait, and this will pass the same way. So don't be attached to any part of the experience. So I think this learning processing you are talking fits very well on this kind of instruction.
Yeah. And did the depressed patients, do they actually suffer more than
I had this impression. Yeah, so as we compare, like we had like 25 health volunteers that took ayahuasca, and from empirical, like looking, as I observed all of them, I would say that the patients suffered more. Like a lot of patients had crying, a lot of crying. Like we know that they struggle in the experience, so they had like memories that were like sad, that gave anxiety. Mm-hmm. And this was not the case for the health volunteers. The health volunteers was very cool experience. Most of them, I think like one or two that had some paranoia or some kind of a little bit more difficult experience, but most of them was like very soft experience. Mm-hmm. And so yeah, but we don't have a measure of this, so it's an impression, no? Yeah. But yes, I would say that's completely true. The patients suffer more than the controls.
We're currently developing a measure to measure these processes, a questionnaire, and I would like to share it with you when it's.
I hope so. Yeah, it's a pleasure. Yeah, this questionnaire, I think, from this Carhart-Harris group, this challenge experience questionnaire, but they published them when the trial was like ongoing.
Emotional breakthrough inventory.
The breakthrough inventory, yeah. So you didn't do this, but we were like trying to measure some of these properties from the interviews. So we are like using these natural language processing tools.
Great, yeah, that's fantastic. I was going to ask that. So in most of the psilocybin trials or the LSD trials, we have seen some qualitative analyses of, and these are really always very valuable. Are you also going to do something like that?
Yes, we are trying in this moment. Yeah, I have a student who are working on this data. Yeah.
Right. Fantastic.
So I think soon we will have some results to share.
Yeah, fantastic. Looking forward to seeing that published. Okay.
Yeah.
Right. So let's talk a bit about the special properties of ayahuasca. So ayahuasca is a psychedelic. I mean, it's very similar in some respects to LSD or psilocybin, but there are also some differences that might influence the therapeutic effects of ayahuasca. So the one thing we've already talked about is the nausea and the vomiting, and the idea that maybe this helps people have emotionally challenging experiences, which is not necessarily a bad thing. So to go through this physical suffering, it may actually help therapeutic processes. What about what about some other possible potential differences?
Well, I think this is a big difference. This nausea and vomiting. Ayahuasca is very known to cause this kind of effects, and normally we think these as side effects. You know, like this is a side effect or it's bad. But if you think in the ritual context, this kind of effect is part of the natural process of ayahuasca. This is not happening because ayahuasca is toxic. So this is part of the purging process. And some of the patients at the end said that this was part of the therapeutic process for them. So it was like they were get rid from something that was make them feel ill. They were like cleaning themselves and removing this kind of if they didn't know what it was, but in somehow this influencing they influence the process. So I think it's very important in the purging is very important. And another difference is ayahuasca. It's the experience normally, the acute effects are shortened than psilocybin. The effects last about 4 hours. So I think can be positive, as we talked that this experience could be challenging. So if they are like shortened, it could be easier to the patient to face them.
Right. Yeah. I mean, I have the idea that also, I mean, you didn't test this in your study, but I know that ayahuasca is often in ritual contexts or in religious contexts, people often use it several times a night. So it does not build up a tolerance. So you can actually take ayahuasca in quick successions. So you can have one ayahuasca session, and then you can have the next one even the same day. So that could be an interesting therapeutic difference to psilocybin, right?
Also, yeah, we didn't test repeated dose, but yeah, in some religions, like in Santo Daime, they normally take two times in the same session. They take one, and then maybe 2 hours and a half after they took another, like the same amount or a little bit less. I don't know.
Yeah. And people often report that they can go deeper the second time. It's a bit like a learning.
Deeper, or they can like sustain the effect a little bit longer. I think because the effects like peak in 1 hour, 1 hour and a half, and then they start to going down. And if you take like 2 hours, then you have like a more sustained effect, and then it's gone down.
So that's
this is very interesting. And there's someone, so we know from the rituals that that's no tolerance, and also that's there is one study that also evaluates the tolerance, and it doesn't seem that have tolerance. Yeah.
What about
sorry.
Didn't mean to interrupt. Sorry.
No, I was like talking about also another thing that I think that's very important in ayahuasca. That's the visions.
Right.
Ayahuasca is very known to elicit visions with the eyes closed, and I think this could also be a mechanism to explain the therapeutic effect. So we know there are a lot of assumptions that the visions are important, as they can see their own memories, autobiographical memories, revisited traumas, and I think this could be also important. And in this in the paper, we show that patients who had more alterations in perception were the patients who 7 days later improved more. So we find a positive correlation. It's not causality at all. So it's a weak, but not that weak, but there's a correlation, a positive correlations between alterations in perception. In this case, perceptions means in vision, basically, and the depression severity, which is very interesting. It could be a
it points to the idea, or the fact that at least it's in line with the idea that these visions have a therapeutic meaning.
Yeah, and also that's this thinking that what happened in the session account for the outcome. Yeah, we didn't. We measured this MEQ questionnaire, the mystical experience, but it was only in a part of the sample. So again, we didn't have the statistical power to evaluate this this kind of phenomena.
Another thing that I was thinking about is that a difference between psilocybin and ayahuasca, at least in countries like Brazil, is that ayahuasca is really culturally more embedded than psilocybin is in, say, Germany, right? I mean, so there are churches. Ayahuasca is also not illegal in Brazil, if I'm informed correctly, right? People are allowed to take it. And maybe that's also a therapeutic difference, right? People could, in theory, they could also decide to take ayahuasca again if they want. They can join one of the churches or do it in some other ceremonial context. Do you know anything about that? Did patients become ayahuasqueros and after?
No. So one thing that was interesting is none of them have heard about ayahuasca before.
Ah, they had not even heard about it.
No, most of them, no. Some of the control group, yes. Because it's different. Like if you are the health volunteers or among the university people. So yeah, most of them at least had heard about ayahuasca. But for the patients, or like the first time they heard about. So this, it's funny because we can have the impression that ayahuasca is very common in Brazil, but I think it's common it's still restricted to some groups. So it's not spread like everyone knows. I think now, yeah, like each time more, but at the time of the study, no. Right, so I think this didn't have an impact on the therapeutic benefits, but the fact that ayahuasca has this legal status in Brazil since 1992, I think, 2 or 3, I know, 9th. And so I think this is very positive because it's easy to study. So we know all psychedelic substances are Schedule 1 in everywhere. And here in Brazil, we have this opportunity to study this substance as we are allowed to study in the lab.
That's really great.
I cannot have in my place, but I can have in the lab.
Right, great, yeah. So that maybe explains why I mean, other countries where psychedelic research is happening, like United States, Great Britain, and now it's starting in Europe, and Brazil is kind of an outlier there, and maybe that's a good explanation that it's just easier to do the research.
It's easier, yeah.
Yeah, right, great, very good that there are countries with sensible psychedelic, or at least laws regarding to ayahuasca, like Brazil. Brazil, I mean, speaking of politics in Brazil, reading the news here in Germany or about what's going on in Brazil, I could imagine that it's a difficult climate for psychedelic research. Is that also a feeling you have, or?
Yeah, so as most of you should know, we are under this extremely right government and with very conservative political views. And I think per se, this is already a problem to study psychedelics and to the psychedelic the science of the psychedelics. But I would say that we are facing a more wide problem. That's a huge crisis in education and in science in general. Like the government cut a lot of the science budget and we don't have money to do any research. So I would say more than something direct to the psychedelic science, I think it's more like the science in general, science and education in general. So it's not a good time to make science in Brazil, for sure.
Yeah. And so what does this mean for your research program and regarding ayahuasca research in Natal? So are you planning any further clinical trials with ayahuasca or any further studies?
Yeah, so for now, we don't have any funding to do any research. Not here in Brazil, we have to find them abroad. And as we collect a lot of data in this trial, we are still analyzing data. So we had like these interviews to analyze, this EEG data also, some fMRI. And So I think for like 1 year or 2 years, we are still good in terms of data. But I hope we will do the follow-up of this study. I will be happy to do a larger study, including more patients, and also with a scheme of treatment. Because, you know, like, even if we don't, I don't know for sure what happened 1 month or 2 months after the dosing session, I don't expect that this lasts forever. So maybe what you need to think is something about some kind of scheme of treatment. Maybe 3 doses separated by, I don't know, like the churches do. Normally the ritual we use is each 2 weeks they have a session. So maybe we can do something like this at the clinical context also, like trying several doses and looking these patients for a longer time.
Yeah, that would be really, really interesting and important to do. So I hope you can secure the funding.
I hope to do, yeah.
Yeah.
Maybe
right.
in the next, I don't know, 5 years.
Yeah, sure. Yeah. Okay. So I'm looking at the watch, and I see that we're almost through with our. There's one more topic that I would like to discuss with you. But before that, I would like to remind our audience to please post your questions on the Q&A. We don't have many questions so far, so if you can think of any interesting questions related to what we've been talking about, related to ayahuasca for treatment-resistant depression, then please post your questions in the Q&A button. And there's one more topic that I'd like to discuss. So very recently, Jordi Riba has died. He's one of the co-authors of the paper we've discussed today, and he is probably, it's fair to say, one of the most important figures in the psychedelic renaissance, in the reemergence of psychedelics in science that we've seen in the last 20 years. And so he started bringing ayahuasca to the laboratory when this was really an obscure thing to do, like when most people wouldn't consider this a serious research topic. So yeah, so sadly he died very recently. Fernanda, have you met Jordi Riba?
Yeah, this was very sad news. Well, we met here in Brazil 10 years ago, I think, and he was a very good friend, especially from of Braulio. Braulio had a more contact with him. But I remember, yeah, he shared a lot of common interests with Braulio. Besides the science and ayahuasca, also he was a pilot.
Right. Yeah.
Yeah.
So I saw the photo, and there is this obituary. Abigail posted it on the chat. There's an obituary for Jordi Riba published at Chacun.
Yeah, the photos from Braulio.
Right. Yeah. So they flew together in a plane.
They flew together. I think in a conference. I didn't remember which one, but yeah, they had this flight together.
Right.
And yeah, for us it was very important in the preparation of the trial, as he had a lot of experience in this placebo-controlled trial. He did a lot of double-blind experiments in his lab. So we changed a lot of thoughts on developing the placebo and how the best way to do it. And yeah, and through the study also very important opinions on how to conduct the trial. And yeah, I think it would be missed for the ayahuasca community and for the psychedelic community. He was very important in also helping people to have like less prejudice against the psychedelics, no? And also proving that they can be therapeutic in some context, like the clinical context, and safe. I think he had a lot of works. He published like a lot of works, like, I don't know, 80 papers.
Did a great service for psychedelic.
I have no doubts that his work is very important and it still be important.
Yeah, very sad loss indeed.
Yeah, it's very sad, very saddened.
Yeah. Okay, so there is one final question. This is actually a question that I ask all of my guests in Zooming In. So Fernanda, could you name for our audience maybe one or two academic papers or books that you would like to recommend, something that has influenced or enriched your views of psychedelics or psychedelic therapy that you like to recommend to our audience?
There are two books that were the first two that I read when I was starting to investigating ayahuasca. Is this The Antipodes of the Mind from Brain Institute, and the DMT, the Spirit Molecule, the Strassman. So they are books. They are not very scientific, like a paper, but I think it's very interesting as they share a lot of experiences. And for someone who had never heard about ayahuasca, as was my case when I first started, it was very interesting to see what people told about the experiences, and also they speculate a lot on the mechanisms and in the meaning of the experiences. So I found interesting.
Yeah, those are really good recommendations. Abigail posted them in the chat in case you want to look them up or buy them. So, okay, I think it's time for our Q&A. Fernanda, can you see the questions we see here? Do you see any question that you like, that you find interesting? So there's a very simple one here that came to me. What kind of Aya did you use? Aya, what's Aya? I suppose Aya is short for ayahuasca.
Aya is the nickname of ayahuasca.
Right. So what kind of Aya did you use?
So there are two very interesting questions. So the ayahuasca was prepared from a friend of us from the Barquinha church. And he prepared this ayahuasca, and we used one batch for all the study. And someone is asking about the dosage comparable to ceremonial dosage ENDS. We tried to use the same dosage. So we did 1 ml per kilo of the subject. So it was almost the same they have in the ceremonies. Mm-hmm. And we dosed DMT and the Armala alkaloids on our sample, and comparing with Jordi work and also some other Brazilians' work, we can say that the level of DMT was medium, was not that strong. So it was not, we had a concentration of DMT that was in the middle range of the other, comparing to the other studies.
Mm-hmm. Right. Do you see any other question here that you'd like to answer? Great questions here. It's always.
Can you please tell me about borderline personality disorder in Aya? So we had a recent work with Rick Zeifman.
He was on the show already, yeah.
Yeah, so Rick Zeifman, he's from Canada, and he contacted us to work together, and we reanalyzed the data regarding suicidality scores. And we also found very promising results, even though we could not see a difference between ayahuasca and placebo. So we don't, because the samples, again, we are not a large sample, and also the scores for suicidality were already low. But even if you look only for the ayahuasca group, we see a very important effect size in the decreasing of the suicidality scores. And especially, this is especially important because borderline disease is related to suicidality. So in this paper, we discuss a little bit about the borderline and how ayahuasca can be helpful in this disease, which there is no specific treatment for borderline, you know? So I think it could be important, it could be interesting.
Yeah, I would like to.
But unfortunately, we didn't have the size to do any statistics. So we have impressions, and yeah, the impressions it works for people, for patients suffering from borderline disease.
So this is something that is being discussed now in the scientific community. There is a paper by Rick Seifman. Maybe Abigail, you can post it in the chat. This was published earlier this year in the Journal of Contextual Behavioral Science, and I talked about it with Rick on the Zooming In webinar a couple of weeks ago. And this is a paper where he argues from a theoretical basis that psychedelics should be investigated as a treatment for borderline personality disorder. It's very recommendable paper. Perhaps you can look it up and post it in the chat, Abika.
Yeah, I think it's interesting because it was not a choice. It was, how I can say, well, we didn't design the trial to include them, the personality disorders, but it happened that when we are searching for volunteers, most of them had borderline, or we had one with narcissism also. And then we were like, okay, we need to include this kind of patient, because this corresponds to most of people who had treatment-resistant depression. From the clinics, we know that it's very common. That's why we included them. And I think most trials did not include them because they are afraid from the challenging experiences, because they can be prone to have more challenging experiences. But I don't know, as we don't have the sample size to do any statistics, I cannot tell for sure if they had or hadn't, if the quality of the experience changed between the patients. I can say, again, only for my experience, that patients had more difficult than controls. But inside the patient group, I cannot tell if I have any difference between them. Right. So I think we have to try it. Yeah.
Here's one follow-up question related to what we were talking about by Ann-Kathrin Schlag. Could you elaborate more on the narcissism case? If they received ayahuasca, how did the medicine affect them? I mean, we have to say that this would be a case report, right? We cannot really...
Yeah, this could be a case report, and his patient, he was a young guy who had very severe depression, and he was taking like a lot of medications. Normally we did the screening, and 2 weeks after, the patient participated in the study, because 2 weeks is the time from the washout for the most of antidepressant. And for this guy, he took like 1 month, I think, to withdraw all medications. And so he was a very severe case. and he had a very challenging experience. He told us that he was in contact with the pain all the time. He was like, he told us that he never felt this kind of pain before. So it's a very, very challenging experience for him and for us also to be with him at this time. But then he improved a lot. So he was on one case of a patient that had a big improvement 7 days later, even if the session was challenging. Yeah. So I don't know if it was the narcissism. Could be. Yeah.
Thank you very much, by the way, for this case. It makes me look forward even more to your qualitative paper.
Yeah, I hope.
Yeah, I think these are, by the way, I think the qualitative papers are they're really important. I think at such an early phase in research, it's so important to do qualitative research. And I would recommend to everyone a paper that came out this week, I think, or last week, which is the first meta-analysis, so to say, meta-analysis of qualitative papers. Came out last week by Brexema et al. Maybe you can post that as well, Abigail, where the author synthesizes the results of all the qualitative studies that have been published so far.
I have to look at. I don't.
Yeah.
I don't.
Yeah, I recommend it. So here's there are two questions that are related to more or less the same question. So if I have another, oh no, this is I know there's three already. Okay, now, so do you think in the close future it will be possible to do to study the effects of ayahuasca on depression or anything else in a traditional setting? So when the brew will be given during a ceremony conducted by indigenous curanderos, healers. This seems to be a very interesting point because three people have asked this.
I think ayahuasca. I think if I think with ayahuasca as a medication, I think the context, it's the best context to do it it's the way people normally do in this ritual context, no? So I think it's possible, and it will be very interesting if you can apply some questionnaires in these people who are already using ayahuasca, no? Do some field research. We had some field research, some epidemiological from Paulo Barbosa some years ago, and they show that the regular consumers of ayahuasca present better rates for well-being, less anxiety, and less depressive symptoms from non-consumers. So I think that's some kind of data already that prove or support these hypotheses. And yes, I think it could be possible.
It should be possible, but it's probably more complicated and really difficult to. I mean, that's the reason why we do research in laboratories, is because in controlled trials we need to control as much variables as possible to just isolate the effect, right? The downside of that is
that's why we bring the ayahuasca to the hospital, no? To isolate it, because you know also that participating in a ritual can make you feel better. If you are part of a group, this can improve your depression without any drug, without any substance. So this is the reason we bring ayahuasca to the hospital, and maybe now it's time to to go back to the rituals.
Yeah, and it should be said, you mentioned it already, that there has been a lot of field research on ayahuasca and a lot of studies to describe the epidemiology of these people who use it regularly. And also, I think some research that was like observational studies where people were assessed before and after using normal rituals, right? Traditional rituals, and where they found, for example, mindfulness enhancing
yes,
effects of ayahuasca. So I think the field research is as important as the laboratory research, but yeah, both have their downsides, right? You cannot isolate so well in field research.
Yeah, I think they can be complementary, no? They
exactly.
can, we can profit from both studies, kind of study. And we had like a huge population of regular consumers of ayahuasca. You can see like União do Vegetal, I think they have like 2,000 people who are consuming ayahuasca each 2 weeks.
Only
so
in
we had
in your city?
No, in around the world.
Ah, around the world. Okay. Mm-hmm.
Yeah. But this can be a huge epidemiological study, no?
Yeah. Right. Do you see any other questions here that you find interesting or that you'd like to comment on?
The role of the music in the therapy session.
Yeah, that's interesting.
I
wonder if you might speak a bit more to the role of music in these therapy sessions. I would be particularly interested to hear, anecdotally of course, about any strong preferences, positive or negative, you may have noticed to certain musical attributes. For example, if there was any preference shown for the instrumental of a vocal playlist or vice versa. Thank you, Samuel, for this interesting question.
Very nice question, yeah. So we had like a protocol for the music also. So at the beginning, until 1 hour and 40 minutes, we had only instrumental music. So it was like this Andean music and instrumental music. Then we had a moment in silence. So 1 hour with no music. And then at the end, we put some music with lyrics. And we had some, so one of the strategies we told them that could be used if you are like under some state that you didn't like, was pay attention to the music. So the music, I think it's very important because when you're listening to music, this can help to bring you to the outside the experience in some way. And so we had one that was very funny, not funny, but very, very interesting. That was one patient who was like struggling in his experience, like crying, and he didn't seem to be there, but in other place. And suddenly we put some music very common in Brazil from Roberto Carlos. He's a very, very known singer here. Like,
I know
very,
him.
Do you know him?
I know him, yeah, but I don't associate him with ayahuasca at all.
No, because in the second part of the experience, you put like music in some popular music in Brazil. So he listened to Roberto Carlos, and then he was like back. It was very, very interesting. Like he did like, oh, I know this one. And then he was like back out of this bad trip, I can say. And it was like, and then he only want to listen Roberto Carlos. And the funny thing, it was like, we didn't have much music, much songs of Roberto Carlos. So I had to look on the computer, looking for another songs to play to him.
So you played popular Brazilian music to?
Yeah.
Did you play Tim Maia? That's just a private question.
I don't know if we had Tim Maia, but we had like Caetano, Maria Bethânia.
Oh, great! Yeah.
Yeah.
I mean, that's one advantage in Brazil, that there is actually a lot of really high quality music that people actually like. That's very different in countries like Germany, where there is good music, but most people hate it.
Yeah, so I think, yeah, this was a funny anecdotal story, but after all, we also asked them how they felt, they felt about the music, and all of them reported that it was well, they liked the choice, and yeah, and also if they didn't like, they could tell us to skip this one. So like Spotify, no, I don't like.
I can skip it.
Yeah.
All right. Yeah, we've discussed about this. So in our study that we're preparing, and we're preparing a psilocybin study in Germany at the moment. We'll start at the end of this year or beginning next year, where we will give psilocybin to over 100 patients with treatment-resistant depression. Yeah.
Exciting.
Yeah. And we were discussing this when we were preparing for this study is, should we allow people to skip musical tracks or should we not? Because the music is kind of matched to the experiential arc of the session. If somebody skips a lot, then they will hear some music that is not so suited for this stage of the experience. Yeah. And it would also, we were thinking of being able to, they should be able to mute the music, but not skip.
Not skip. Yeah, for us, we had this playlist, but it was not always played in the same sequence. It was like random in this playlist. So each one listened to a sequence of songs, but it was not very common to them to ask to skip. I remember like once one girl didn't like this music, the music she found was sad, and then she asked to skip.
So it didn't occur very often, right?
No, right. But it was like, yeah, not very often.
So we have time for one more question. This is an interesting one. So helicasic, to find out if the antidepressant effect is caused by DMT or by Banisteriopsis carpi alkaloids. Could you measure the antidepressant effect for the vine only ayahuasca? That's an interesting one. Have you thought about this? So ayahuasca has two main components, and to just study them separately?
So I don't know. What I know is that some animal model studies looking only for these for the Banisteriopsis carpi components, and that they found antidepressant properties, but in animal models. Measuring the Armina, but with ayahuasca, I don't think we can separate them in the ayahuasca as we know, because it's a mixture of both chacruna and jagubi. So, and the ayahuasca, as we know, we need the two of them to have the effects. So, but yeah, I think it's possible to make an ayahuasca, or I don't know if we can call ayahuasca only with the Banisteriopsis vine, and to measure the effects. But yeah, but I don't know. I know this also, that some studies in these mini brains, these models, the 3D models of how I say, of cells, you know, like to study neurogenesis and this kind of studies, that they found also only using Armin, that Armin has neurogenic properties. So yeah, I think it's possible that only Banisteriopsis has an effect, another antidepressant effect.
I believe this was one of the studies also by Jordi Riba, right? He found
he did in rats, I think, in mice. I don't know, in mice or rats, I'm not sure. Yeah, but also here in Brazil, we have this partnership with Steven's hand, which is a research in Rio de Janeiro. And he did a lot of research in these brain organoids. And he found also that Armin has a neurogenic profile when he tested in these mini brains organoid.
All right, so looking at the time, it's already 9 p.m. So this is already over, I'm afraid.
It's late to you.
Yes, it's late. Yeah. So Fernanda, thank you very much for being my guest. It has been a great pleasure chatting with you.
It was very nice also, and the questions also very good questions.
Yeah, very good questions by everyone. Do you have any closing remarks, Fernanda?
No, it's yeah, I'm very happy to share with you to talk a little bit. It's always a pleasure to me to share my impressions on this study. It was like a very, as you said, like it's a big study and here in Brazil with all these difficulties to do research in a third world country, and it's very nice to share the impressions. And I think we had a lot of results to come yet. No, is a talk like someone asked here in the chat about these sleep EEG data. So I didn't know yet. We had this sleep EEG data to look for. I have also some fMRI data. So I think in the next years, we will like write these papers and you will hear about us again.
Yeah, I hope so. I'm looking forward. We will keep our eyes open, and probably I can predict that I might approach you again after you publish your qualitative study, because then we can talk.
I hope so. Yeah.
That would be great.
It's a pleasure.
Thank you very much, Fernanda.
Thank you.
Everyone, so one last announcement. We have another Zooming in 2 weeks with Roberta Murphy. Maybe Abigail, could you share the graphic card, please? So this is going to be a Zooming in with one of the clinicians who was involved in the SILO-DEP2 trial. This is a trial that has recently been completed. They haven't published the results yet, at Imperial College London, where they tested psilocybin against escitalopram, and so a standard antidepressant. And so Roberta and we will be talking about the important role of trust and the therapeutic relationship in psychedelic therapy research. So I hope to see many of you again. Abigail just posted the link to the event in the chat. And yeah, thank you. Oh, there it is. There's the graphic card. This is Roberta. So yeah, I hope to see as many of you as possible again next week, in 2 weeks, sorry. And yeah, this is enough of me talking. Goodbye, everyone.
Bye-bye.